So welcome to another clinical scenario based question in respiratory medicine. So the question here is a 30-year-old patient. So there is an young patient presents with 4 weeks duration of dry cough. On examination, there is also splenomegaly. Peripheral smear shows spirocytes, high reticulocyte count, and also Coombs test is positive. Chest X-ray shows bilateral infiltrations, the most likely causes. Now let us see what information we can gain from this clinical scenario. So no doubt this patient is having respiratory symptoms such as cough and pulmonary infiltrates. So any patient with some respiratory symptoms and pulmonary infiltrates, so this phenomena is called as a pneumonia. So there is possibility of pneumonia in this patient. Now usual presentation of pneumonia in anybody is there can be fever, and because of infection, proliferation of microorganisms within the alveoli and accumulation of inflammatory cells, all this will result in secretions that results in productive cough. But here it is a dry cough. So whenever there are features of pneumonia and it is a dry cough, generally it is an atypical pneumonia. So in the given question, the possible problem happening in the patient is atypical pneumonia. Now along with pneumonia, there are other features also here. There is splenomegaly, presence of spirocytes, high reticulocyte count, and Coombs test is positive. All this indicate presence of some spirocytes, means RBC membrane might be damaged, reticulocyte count has increased, Coombs test is positive. All this indicates chances of some hemolytic anemia. So there is also splenomegaly. So immune mediated hemolytic anemia. Whenever you find these two in association, there is a organism responsible for this. Atypical pneumonia and hemolytic anemia, the organism responsible is usually Mycoplasma. If you find a patient with atypical pneumonia and hemolytic anemia, the organism is generally Mycoplasma. Now why in Mycoplasma there is hemolytic anemia, and what are the other features of Mycoplasma, we will discuss shortly. Before that, why it is not atypical pneumonia due to chlamydia, Legionella, or Pneumocystis jirovecii. See, the other options in the question are also very important because they also can cause atypical pneumonia. But why in this question the answer is only Mycoplasma, not other pathogens. So starting from chlamydia. So chlamydia will cause pneumonia, atypical pneumonia, and most importantly, there will be significant upper respiratory tract symptoms. Patient can be having some sore throat, nasal symptoms, all this. In chlamydia pneumonia, no doubt it can cause atypical pneumonia, but patient will be having some significant upper respiratory tract symptoms. Legionella can also cause atypical pneumonia, but it has some special features. So Legionella is associated with some special features, such as diarrhea. So there can be diarrhea in association with Legionella and other features that I'll discuss in the next slide in detail. Whereas Pneumocystis pneumonia can also present as an atypical pneumonia dry cough, but most important is it is a pneumonia in immunocompromised. Pneumocystis pneumonia usually happens in a patient who is immunocompromised. Because in the given question, they did not mention this patient is immunocompromised. Immunocompromised in the sense patient might be having HIV, he might be undergoing organ transplant, or there are some primary immunodeficiency disorder, long-term chemotherapy or steroid therapy. So it is not pneumocystis jirovecii. And because there are no predominant upper respiratory tract symptoms, chlamydia is also unlikely. Then atypical pneumonia, there is no association with diarrhea and other special features pointing out towards Legionella, so it is not Legionella. Atypical pneumonia with presence of hemolytic anemia, generally the suspicion should be Mycoplasma. Now going in detail, the important features of Legionella and Mycoplasma. Actually, these are not differentiating features, just list of features of Legionella and list of features of Mycoplasma for your convenience. In Legionella pneumonia, along with lung involvement, there is GIT involvement. So GIT involvement such as diarrhea, CNS involvement, confusion. There will be high grade fever, temperature will be more than 40 degrees centigrade, and involvement of liver, systemic involvement, there can be altered LFTs. There can also be hyponatremia. So these are some clues for diagnosis of Legionella pneumonia. So if you find a patient with atypical pneumonia, you should look for these clues to diagnose it as Legionella. So what are the clues? Is it associated with diarrhea, confusion, high grade fever, altered LFTs, hyponatremia? And this is an atypical pneumonia, and the response to beta-lactams will not be good. So routinely given antibiotics such as beta-lactams will not function here. And Legionella is spread through contaminated water. So when can you suspect this to be Legionella? Whenever you find water sources contaminated with Legionella. Occurrence of illness in environment where potable water is contaminated with Legionella. And generally contaminated water will be found in hospitals. And this patient might get infected with Legionella in the hospital because the incubation period is variable from 2 to 10 days. Patient may not manifest this disease immediately in the hospital. He might be discharged and later at home he can manifest this pneumonia. Onset of symptoms within 10 days discharge of after discharge from hospital. Also you should suspect Legionella. So if you find a patient with atypical pneumonia and one of these features, one suspicion should be Legionella. Whereas Mycoplasma, it is most common atypical pneumonia. Mycoplasma is the most common atypical pneumonia. So this Mycoplasma is also called as eaten agent pneumonia, also called as walking pneumonia. Whenever somebody develops lung infection, these patients, because your lung is very important for oxygenation, whenever it is diseased, patient cannot do exercise or cannot do routine activities, he might develop breathlessness. But Mycoplasma pneumonia is generally a mild presentation. Patient will be having pneumonia and still can perform his routine activities such as walking. So that's why this is also called as walking pneumonia. It means patient is having illness but still can do his routine activities like walking. So that's why this pneumonia is called as walking pneumonia. It means in majority the presentation of Mycoplasma is not that severe. But in few patients there can be extra pulmonary features. See, extra pulmonary features are not that common with Mycoplasma but are very, very important for your exam. So what are the extra pulmonary features that you should know? So these are the extra pulmonary features. Within the skin there is rash. Erythema multiforme can be seen, erythema nodosum. So skin lesions such as erythema multiforme, erythema nodosum can occur as an extrapulmonary feature in Mycoplasma pneumonia. Whereas in the neurological extrapulmonary features, because of systemic involvement of the brain, there can be encephalitis. And few patients who are having Mycoplasma pneumonia can later on develop Guillain-Barré syndrome. So this was previously asked. So which of the following is an extrapulmonary manifestation of Mycoplasma? So many features were given. Out of that, the correct answer was Guillain-Barré syndrome. And coming to the hematological features, as discussed in the question, in Mycoplasma pneumonia, there is increased cold agglutinins. So there are few antibodies generated in the body against RBC. So when they react with RBC, there can be hemolytic anemia. And this is a hemolytic anemia, and it can be identified by Coombs test positive. So very, very important. In Mycoplasma pneumonia, there is presence of cold agglutinins in the body, and patient has tendency to develop hemolytic anemia, and this hemolytic anemia you can identify with help of direct Coombs test. It will be positive. And cardiac manifestations in the form of myocarditis, pericarditis, and within the joints there can be development of arthritis and results in pain in the joints, arthralgias. These are the important extrapulmonary features of Mycoplasma. So in your exam, whenever you find a patient with pneumonia and diarrhea combination, whenever you find a patient with pneumonia diarrhea combination, your suspicion should be Legionella. So generally that pneumonia is atypical pneumonia, atypical presentation. Whereas a patient with atypical pneumonia along with that hemolytic anemia. So typical pneumonia, generally patient will have fever and productive cough, and he will have some consolidatory pattern alveolar infiltrates in the chest X-ray. Atypical pneumonia means patient will be having fever, not so high grade. One most important thing here is the cough. It will be dry cough, and on the chest X-ray you may not be able to see dense alveolar infiltrates. Most probably it will be interstitial involvement. In the question, if one identifies pneumonia plus hemolytic anemia, so if you find these two in combination, pneumonia plus hemolytic anemia in the combination, so it can be Mycoplasma. So this is the important features of both Legionella pneumonia, Mycoplasma pneumonia. These two are frequently asked atypical pneumonias for your exam. So these are the new pattern of questions that can be asked in the upcoming exams. So we have some clinical scenario, and we have given some investigation background, and they are asking you what is the organism. So they are asking you the etiology. So all this new pattern of questions are vital for not only learning the concept but also for your exam. These will form the core group of questions. Out of 100 questions, 60 to 70 will be concept based questions like this only. Only few questions might be memory based or direct questions. So all this will be available on the eMedicos app and the DAMS question bank. So go through it and make sure you are up to date with this new pattern of questions. Thank you.
Thank you.